Conversations in Frailty, the podcast for Derbyshire clinicians.
Hello and welcome to what I believe is now episode 9 of Conversations in Frailty, and today we will be thinking about gout. I had the pleasure of having a couple of chats with one of our local rheumatology consultants, Dr. Ding, and this is the first of those. But before I launch into gout, a little apology to listeners. If you enjoyed listening to episode 8, which was anxiety in the elderly, you may have wondered why at a random moment in the conversation the theme tune bursts in. I am fond of this little jingle, but I have to admit this bonus moment wasn't planned and it has now been cleared up. So if you haven't already listened to that one, do go and do so, and it should run seamlessly, as I hope today's will. So why did I choose gout as a topic? Well, it's a condition that we see reasonably often in our frail elderly patients, and when asking around colleagues, certainly people came up with a range of questions that I could put to Dr. Ding. As ever, there are times when the guidelines out there are more challenging to apply to this particular patient group, so we focus very much on thinking about how we manage this population today. Dr. Ding did say it's worth drawing attention to the gout guidance on shared care pathology, which is really helpful for all the basics in terms of the numbers, urate levels, drug doses for managing acute attacks, and starting doses of urate lowering therapy and so on. So yes, do go to the shared care pathology, and also the CKS NICE have excellent guidelines for managing gout in any standard situation. So the first conversation today, we very much think about how gout presents in our frail elderly patients and thoughts about managing acute flares. So here I am today now with Dr. Ding, who's kindly agreed to talk to me. So just for the listeners, can you just introduce yourself for us? Tell us, where you're working and how long you've been there.
Thank you, Sarah. I've been in Royal Derby Hospital, or now we moved to Florence Nightingale, as a rheumatology consultant for the past 16 years. In fact, I trained in initially Cambridge, and then my rheumatology training years were in Oxford, because then when I nearly finished it because my husband got a renal job here. Then I moved my number for the final few months. And the rest are history. And then Derby appointed me, so that's how it started. Yeah.
Lovely.
Yeah.
And I often ask my interviewees, just tell me something about what you like doing in your free time, to give us a little bit of a different picture about you. So.
Yeah, I think exercise medicine is important, and I do enjoy exercises like table tennis or badminton, and more recently paddle as well. I think I have a group of consultant colleagues here, also very exercise orientated, and we're trying to pass that to the patient. We did an osteoporosis session, and inviting patient to go to the pedal center. We are pedal in Pride Park, and testing them on knowledge about bone health, and then asking about what sort of exercise. But obviously pedal will be one of the exercise that will improve their bone strength. So yeah, I think it has been very beneficial for myself to be able to maintain a variable exercise plan. As I gradually get older, some of the more intensive exercise is less optimal, but to have a very diversified exercise routine helped me to continue with this very useful hobby or habit into my older age. I want to pass that to the patient as well.
Great, yeah. I seem to have quite a lot of active consultants and nurses who I'm interviewing, so that's great. So onto our topic today, which is gout. So obviously this is a conversation in frailty, so we're focusing in on that population. Just start us off, tell us a little bit about the prevalence of gout in this group.
Yeah, gout is actually more common than I initially, as a junior doctor, think in the elderly, and the prevalence goes up with age. For instance, it's if you're in your 40s, it's approximately 3.3%. The data we usually quote goes up gradually to over 80s. You're looking at 12.6%. So 4 times more. I think the other thing that's quite special in this age group is in the younger patient, we all know is male predominant. It's very rarely to have pre-menopausal women to present with gout. Maybe some genetic predisposition in those very unlucky younger women, but usually it's male, like 12 times more than women. But as the age goes up, the differences between the different sexes is actually much less. It's probably 2.5 times more in men than women. So women just got more and more gout as they pass the menopausal age usually. And also, I think the other special thing about gout in older people is the younger one tend to be alcohol. If you tell them to drink less, they often make a big difference to the gout flare-up frequency and intensity. But in older people, lifestyle modification has been shown in trial to be very, well, not effective at all. So, of course, if they drink a lot, you still ask them to reduce it, but you will need to work on the urate lowering therapy more as you can't bank on changing diet to solve the problem.
Okay, well, I think that's helpful to know because it is always a balance, and for some patients, actually, some of the lifestyle they enjoy diet-wise and things, we don't want to reduce needlessly, do we? So, that's really helpful. And when we're looking at just the presentation of the condition, does it differ when we're looking at our frail elderly patients? Does the gout present in a similar way or a different way? Would you say?
I would say very different actually. In a younger patient, often textbook example will be a male in their 40s, 50s with a big toe that looks very red and hot and angry, and they will have attacks, and then they'll be perfect in between attacks. For older people, even when they present with very few joints, like less than 4, there's sometimes it could be atypical symptoms, maybe not as red that you would think it should be, maybe not as pain, because I think gout pain to a man been described like labor for women, so is that bad? So in older people, the pain might not be that bad, and then they might not have a history of previous attacks. And then probably the most common presentation is actually multiple polyarticular presentation, frequently affecting knees, ankles, and wrists that you probably don't normally think about gout as a first differential. And then often the other features can be quite troublesome. I think is that they might come in with confusion and fever, and you're thinking, is it gout or is it actually another infection? So often there is a superseded infection, but you could have, with no infection, gout itself can send older, especially even, well, if we talk about 80s, 90s, I think have a polyarticular gout flare. It might be triggered by a little virus or cold, but that's gone. You don't need antibiotics. And you're saying, why is it so confused? But it could be gout. So I think very different to younger patient with gout presentation, and all challenging really.
I think that's really helpful actually, because it's not one that we often, when we think about delirium now, work through the sort of pinch me acronym, but actually just keeping, I think it's always important, when you're thinking P for pain, actually is it a gout pain, and that's part of a trigger and so on. So that's really helpful. So yes, it's not necessarily the nice straightforward big toe. It can be a lot more complex in this group, can't it? And then thinking about, obviously one of our main differentials that we always worry about is the septic arthritis. So just what are your thoughts about, in one of these patients, how we try to distinguish? What should we be doing?
Yeah, I think it's quite challenging. because septic arthritis can present very similarly to gout and is not infrequent at all for patients who get admitted to hospital later on diagnosed with gout, that you look before their admission, GP often have been giving antibiotics for suspected cellulitis because you just look so angry and red and puffy, and that's all the signs of an infection. And then specifically about septic arthritis, infection of the joints versus gout affecting the same joints. I think in older people, you worry about more joint infection than younger ones. So it's definitely quite a headache when you have those cases. I found it personally helpful to divide into very few joint involvement, 1 or 2 or 3 still can happen as a gout presentation in older people, and polyarticular, i.e. both hands, wrists, both feet, ankles. I think in the few joints, then septic arthritis is definitely differential, and you would do the whole thing. I think aspiration, gram stain, it is the gold standard. I think now that medical aesthetic is much easier access for GP, I think if you suspect it, there's a definite possibility of being having septic arthritis, not just either cellulitis or mild gout. I think you should have a low threshold to refer into medical aesthetics, which they can access us. They do the initial septic screen, and then they'll get us involved. We'll tap the joint, or even orthopedic team as well can tap, depending on which joint involved. If you have a polyarticular presentation, I think the chance of, unless the patient is gravely ill, because if you have infection in multi joints, the patient normally very sick.
So hopefully we're not going to miss that one.
Yeah. So if they're not that sick, and the chances of having crystal arthritis, like gout or pseudo gout, to be honest, that's also very common because that's associated with OA, which is more common in older people. And those are, we call it together as a crystal arthritis or polyarticular crystal arthritis flare. More likely than septic arthritis if you've got so many joints involved and patients don't look gravely ill. But the gold standard is always, if possible, try to tap the joint.
So as you say, that's not something we tend to do in the community, but actually with aesthetic, they could come up. And they
could. They will also do the other things. But then, even if you got access to white cell count, it goes up in gout, goes up in septic arthritis. CRP goes up in both. Even radiology, X-ray changes are not that early. There are classic gout features, but that usually happen later. So acutely, I think the investigation that we have to hand easily, even for you guys, it's not been that helpful to differentiate the two.
No, fine. Okay, great. So I think we wanted to move on then to a little bit of a chat about actually those acute flares, because there's quite a lot to think about around when we have someone with an acute flare, how we best manage it in this patient population.
I think the BSR latest guideline for gout management is 2017. That's superseded by the NICE guideline for gout management in 2022, and that is what we base locally for gout management, and that's accessible through intranet. So that is cover gout patient in all age spectrum, and I found that purely using the guideline is quite is not often not enough to help me when we're dealing with older people, because this group of people, some have hepatic ulcer disease, kidney impairment, renal impairment, where you just definitely will not be giving NSAIDs. Colchicine as well, because they may have a liver disease, kidney disease. There are medications that induce the inhibitor cytochrome P450, drugs like antibiotic erythromycin, clarithromycin, fluconazole, or even calcium channel blocker. So then using even small dose of colchicine, as the guidelines say, can be fraught with problems. So we often find ourselves give steroid. Now, systemic steroid orally can at higher dose or in a very a patient with severe heart failure can actually make that worse. So I think we tend to, I find myself use, if it's a few joint that's accessible for intra-articular steroid injection, that would always be my favorite option first. Of course, if they are older patient but don't have kidney, liver disease or heart failure, then your option obviously more, and then you can just go by the NICE or the local guideline, using NSAID and colchicine for acute flare. But if in doubt, I think I find myself injecting more often when I can, or using oral steroid. Now, the dose of oral steroid, are you going to
talking prednisolone?
Yes, that's right. That we would suggest to give, if it's depending on how many joints. I think you guys always try to use the lowest dose, the shortest period when possible. So although the guidelines say if when you give oral steroid, the dose is 30 to 35 milligram daily for 3 to 5 days. But if you only have a few joints involved, I think I would suggest you use a lower dose, 15 to 20 milligram. Just use your own judgment. But if it's everything's flared up, giving 10, 15 milligram pred is not going to be enough. Then they obviously then will go by the guideline. Hopefully, the patient do not suffer from severe heart failure. That's always the problem, isn't it? So I think use judgment, but
And is that useful as a kind of rescue pack? Just talk. Because we use prednisolone, COPD exacerbations, we get patients to jump on those at home sometimes with rescue packs. So what's your thoughts about that?
I think if a patient have a good understanding, and some of my patients love steroids, I think if you get a feel that they truly understand, if it's not severe flare, they should opt for the maybe 15, 20 milligram rescue pack rather than the higher dose. Or if I'm not sure, I just give them the lower dose, because it's a rescue pack, isn't it? It's not the acute management when they have when they have a flare like the guideline dictates. I think that is what we tend to advise more. The data shows that for patients with established gout, if you can give them acute treatment early, and that will shorten the flare, reduce the longer term functional reduction, because often when the joint's been active or flared and with pain and can't move, patients don't recover just when the inflammation goes. They will still have problem moving that joint, the muscle not working as well, that we can need a physio input. They lost confidence, they tend to fall more. So the shorter they stuck in the period that they can't use the joint, they can't walk, the less longer term impact it will have. Because a lot of these gout, they might come from home. Each time they come up with a bad flare to hospital, you find they actually go back home don't go back home anymore, go to residential home, and the next admission they might have to end up in nursing home. So I think short term, if you know that is the diagnosis, the top differential, you treat it and trying to give them early. If the patient is very good up there, can spot early signs, and then just give them a rescue pack.
So jump on it quick.
Jump on it quick.
That's really helpful. And if they are one of the patients where actually we think, bloods are okay, colchicine is going to be reasonable to try, what is the sort of, it's sometimes hard to know how long we should keep it going for. So if it's for an acute flare we're using the colchicine, what would be your sort of duration?
The guidelines suggest 500 microgram. If you look at BNF, I think some of the older copies do say hourly, and that's just too much. So the guide is 500 microgram twice a day, 2 to 3 days. I think you do need to exercise a bit of a judgment here, because depending on how many joints, isn't it? I think the one I see, 3 days usually not enough, because those ones are having such a bad flare, they actually hospitalized. A 3 day is not enough, and I find myself reaching for steroid quite quickly, because it's not even able to hold it, and never mind turn it around. So so depending on how many joint, guideline is 3 days. And then as prophylaxis, when you start urate lowering therapy, then that will be 6 months at a lower dose, 500 microgram daily.
Okay, so so that's the different scenario where we're kind of using it to cover the allopurinol initiation, as it were.
That's right.
Okay. Great. Well, I think we've probably covered enough for today. So we've gone over the presentation, and we've been differential with the septic arthritis and looking at the acute flares. So I will look forward to talking to you again, and we will carry on this conversation a little bit more around the prophylaxis and some special sort of cases with comorbidities.
Thank you.
Thank you. So I hope you'll agree there was lots of useful information that Dr. Ding shared with us there. Thinking around presentation, actually, it's as sometimes with other conditions, it may be less severe and dramatic in this population. However, it may also be quite dramatic if their gout precipitates delirium. So something to always have in the back of our mind. I think a useful learning point for me was to have gout as a thought when we're seeing a case of what had originally thought to be cellulitis that's around a joint area. And if we see it and it's not responding to antibiotics, just think carefully, could this be a gout presentation? And obviously she's covered really helpfully the acute flare management. I think it does seem that often we'll end up having to go towards the low dose prednisolone because of contraindications to the more typical medications. In an ideal world, we would be giving intra-articular steroids in some cases. So whilst there will be patients who are not keen to go up to secondary care, I think for those who are, that is an option that we should hold in our mind. The SDEC can be really helpful, both to confirm a new diagnosis of gout and to give some injections which could really quickly help to settle down flare-up. So those for me were some really useful learning points, and I'm sure you will have taken away some others as well. So I do continue the conversation with Dr. Ding and talk about urate targets, troublesome tophi and management with comorbidities. So do listen out for episode 10 where we'll be covering those. As I always say, do remember that this was a conversation with one individual expert in the field. So if you're making clinical judgments about individual patients, then take local guidance and your own clinical judgment carefully into account.
Conversations in Frailty. Thanks for listening.